So today's topic might feel in some respects a little bit ripped from the headlines as we're dealing with what is been called a crisis in clinician burnout, as well as hospital systems under pressure in a variety of ways. And at this kind of steady drumbeat of information about healthcare disparities across the United States in a variety of different dimensions. But anyway, so we're kind of sitting at this junction of distress, burnout, hospital systems under pressure, and a number of different are consistently reported upon in the popular press as well as in academic literature. And the starting point for our discussion today is the idea that these three things are not disconnected or unrelated from one another. The thesis, right, that they are related is increasingly being explored, not just in the academic literature. Here you see the American Journal of Bioethics exploring some of those connections, but then also in the popular press and media, considering some of the interrelationships between health systems under pressure, inequity, and physician burnout and moral distress. So here as an organizational ethics consortium, what we're going to do is focus in and zoom in on the healthcare organization and how it can be a force for good, in particular considering how institutional commitments to equity can support frontline physicians and their patients, and really facilitate some kind of progress in what is admittedly a difficult system to work within. We've got an amazing panel to take us through today, 3 in person, 1 who will join us online shortly. And I'd like to introduce each one of you. So first, we've got Dr. Katherine Peeler, who's a critical care physician at Boston Children's Hospital. She's an expert on health and human rights with a focus on detained immigrant children. And what brings Katie here today is her attentiveness to how these and other vulnerable populations can all too easily fall through the cracks of this really complicated healthcare system in which we work. And Katie is also teaching faculty at the Center for Bioethics and a fellow in the Justice, Health, and Democracy Impact Initiative with the Safra Center for Ethics, also here at Harvard University. So welcome, Katie. To have Dr. Thea James here sitting to my left, coming to us from just down the street at Boston Medical Center, where she's Associate Chief Medical Officer and the Vice President of Mission. And so Thea focuses her work squarely on public health and health equity, with a particular focus, I think, on African-American populations and racial disparity as well. And so Thea is also professor of emergency medicine at Boston University Chobanian and Avedisian School of Medicine, and has led a number of violence and disaster response programs and teams that have taken her from Boston to New Orleans, to Iran, to Haiti, and perhaps other places too. So it's really a pleasure to have you back at the consortium today, Thea. And then we have Dr. Omar Lateef, so coming to us from Chicago, but physically in person with us in the Boston space, formerly Chief Medical Officer and now President and CEO of Rush University Medical Center, President of Rush University University System for Health. And under his leadership, the medical center was receiving national attention for its effective response to COVID-19, and also more broadly, its strategy on health equity. So Omar is also nationally recognized in the field of healthcare quality measurement and has worked with academic medical centers across the nation to look at the factors and methodology involved in quality rankings by CMS, as well as US News and World Report and others. So it's really no surprise to us that Omar was recently named among the top 100 most influential people in healthcare in the United States by Modern Healthcare in 2021. And we're really happy to have him with us today. Fourth person who's joining us in just a few minutes, jumping from another meeting, and that's going to be Dr. Vikas Saini. He's president of the Lown Institute, which is a nonpartisan think tank that works to advance a more just and caring health system. He's a clinical cardiologist who trained at Harvard, where he's also taught and done research. And Vikas leads the Lown Institute's signature project, which is the Lown Institute Hospital Index, the first ranking system to really measure social responsibility of hospitals directly. And that includes quite novel metrics, things like pay equity, for example, avoiding overuse, and racial inclusivity. And so Vikas also serves as the co-chair of the Right Care Alliance, which is a grassroots network of clinicians, patient advocates, and community leaders who are looking to organize to put patients rather than profit at the center of the healthcare system. Like I said, Vikas is going to find us in just a few minutes, and I probably should have advanced the slide to let you all know who we're talking about here. But we're really thrilled to have you with us. And I think with that, I'm going to turn it right over to Katie to get us started in the panel conversation for today.
Great, thank you. And Omar and Thea, these need to be on when we speak, just an FYI, which sometimes I get that wrong. So thank you so much, Kelsey and Charlotte, for allowing me to host this. Thank you for everyone being in person and for everyone who's online. I really appreciate you being here. I'm thrilled, very, very humbled to be surrounded by this panel and honored to moderate a conversation with its panelists. So as a grounding framework, I wanted to just put forth a definition of health equity. I know we talk about it all the time, but just to make sure we're all on the same page here. So as defined by the CDC, we talk about health equity as the state in which everyone has a fair and just opportunity to attain their highest level of health. So achieving this, the CDC goes on, requires ongoing societal efforts to address historical and contemporary injustices, overcome economic, social, and other obstacles to health and healthcare, and to eliminate preventable health disparities, which sounds great. But as Dr. James once said, which has been echoed many times by Dr. Lateef, people are able to create entire careers on uncovering disparities without actually connecting it to a plan and intentionality to eliminate them. So hospitals often say they have a plan, but physicians who are in the trenches often don't see this plan. This isn't great because on the one hand, physicians might start to wonder whether equity really is a priority for their institution and start to lose faith. On the other hand, if their hospitals' plans and systems that support equity are there, but just aren't clearly communicated, physicians find themselves in the tough position of not knowing how to actually access the resources in their own hospital to deliver the care their patients deserve. So to set the stage for this discussion, I'd like to start with two stories. These both come from my hospital, a place of incredibly high quality care, and I believe truly committed to achieving health equity. But as with all hospitals, we still have much room for improvement. In sharing these stories, I hope to frame where I see some of the fundamental intersections and breakdowns between hospitals' commitments to health equity and the moral distress clinicians feel when they're working in these systems and yet can't seem to get what they need for their patients. From there, I'm hoping to turn to our panelists to help us understand how some hospitals have shown their commitment to working towards health equity and what it can mean to translate that commitment to the on-the-ground work of the individual clinicians seeing individual patients. So Aurelio was a 3-year-old boy. He was admitted to my service in the pediatric intensive care unit, and he had recently emigrated from Honduras with his mom. They were hoping to reunite with his father, who'd already come a few years earlier. Since infancy, Aurelio had seizures. He had difficulty swallowing. He was small for his age. He hadn't met several milestones. He couldn't sit or walk. And despite his medical history, his mom and his extended care family in Honduras had taken incredibly good care for him, feeding him by mouth as they were able to, giving him his anti-seizure medications as prescribed by his Honduran physicians. And so he initially presented to our ED with cold symptoms, but recognizing the many other issues that were going on, he was ultimately admitted. After a long hospitalization working on his seizure medications and other things along those lines, he failed a swallow study and his family decided to have a gastrostomy tube placed so he could receive nutrition and his anti-seizure medications safely without aspirating. Aurelio's mother also disclosed to me that their housing was insecure. So as he was getting ready for discharge, I discussed his many needs with our senior social worker, housing assistants, compounded liquid medications, formula, gastrostomy supplies, all the things that we need to safely discharge someone home so they can successfully, ideally, not come back right away and thrive on the outside environment. She told me that there was very little she could do for this family since they had arrived here, quote, without papers, end quote. And as we've all heard in the news, there's almost no permanent public housing options available, at least right now, to undocumented immigrants in Massachusetts and most of the United States. Furthermore, the social worker suggested that we start to set the family up with care at a neighboring hospital, quote, because we do not provide free care here, end quote. She felt the child would be more likely to receive the therapies and medications he needed if he instead established care at the other hospital. I was devastated, and I felt like I was abandoning this patient and concurrentently about to, quote, dump, a phrase I don't like, but is used frequently in a lot of the articles that Kelsey mentioned, are underinsured patients. This felt like one of the moments where equity didn't seem to be a priority, and I was left wondering, could we be doing more? The second patient is of a 9-year-old girl with a rare syndrome that causes issues in multiple organ systems. As an infant, she'd had complex congenital heart disease, and it was repaired, and she was stable, but it still required intermittent monitoring. More recently, her active issues were with her vision and her hearing, as well as her dentition. All of her care was primarily at a different hospital in Boston, and she was doing relatively well, but was at risk for further progression, particularly within her vision and hearing difficulties, and needed exams in these areas to help assess her current status and plan optimal interventions. She additionally needed some dental work. Behaviorally, she could only undergo these exams and interventions under general anesthesia. The anesthesia team assessed her at her primary hospital and felt that her cardiac risk was high, and she thus should come to our hospital for her exams with a dedicated cardiac anesthesia team, a team they just simply didn't have at their hospital. The plan was that she would return to her own hospital for continued care after her examinations. However, when the referring hospital tried to set this up, the referral was denied by us on insurance grounds, and the result exams. And while these seemingly elective procedures didn't happen, the exams and the procedure were essential to her sight, hearing, and oral health. The referring clinician was dumbfounded and disheartened. I did discuss these cases with my hospital and learned that there is much more nuance for how we could have helped these patients than understood by many members of the care team at the time. Nuance about free care that we do provide, but is not always known by physicians. Nuance about how to appeal a rejected referral. Nuances about what resources we do and do not have and how to best navigate our system. But if clinicians are not privy to these nuances, what ensues is the very physician moral distress that I experienced, that the referring physician experienced, and that trainees and attendings relay to me almost daily. So as Kelsey mentioned, physician moral distress and burnout is widely reported in the literature and popular media today, and we hear about these issues at systems and hospitals. When a poster or a website state clearly and succinctly that a health system to health equity, there appears to be no nuance, no asterisks, no fine print. But hospital systems are incredibly complicated with various factors, finances, mission, education, innovation, other things to consider when implementing changes. So of course there's nuance. But if a clinician does not truly understand the system in which they are working, they end up discouraged, frustrated, and potentially disillusioned. Just as we want our patients to be informed consumers, we too want to be informed users. And importantly, we want to be part of the progress. We need to be informed reformers. So today we're going to explore some examples of endeavors that hospitals have undertaken in advancing equity, how they've allied with clinicians on these endeavors, and how external metrics and forces like hospital ranking systems can help all of us do better. Through it all, we will need to consider some of the challenges and ask, what is the margin of space in which hospital leaders actually have freedom of action to make things more equitable today? As one of our panelists said during our pre-meetings for this moderation, it is, quote, less than many understand and more than many of them claim. And if that's the case, where does transparency come in with regards to simply telling frontline clinicians what a hospital can and cannot do to achieve equity in the present and what their timeline for change looks like? I contend that the root of physician moral distress in this space is the cognitive dissonance when trying to reconcile hospitals' public-facing comments and campaigns about health equity with the reality of the systems that stymie much of what clinicians feel is necessary to achieve this goal. So I'm hoping now to turn to our panelists who have a lot of experience in this and a lot of success. Lots of hospitals are publicly committing to providing equitable care, but clinicians don't see that come to fruition and how they're able to practice. And so I guess my first question simply is, have you seen that at your institutions, at Rush and at BMC? And can you tell us a little bit about how you've grappled with that? So Thea, I'll start with you.
Okay. So I hope I'm answering the question correctly. But I guess I have to back up just a little bit because, our hospital probably was that neighboring hospital. But, our hospital is a hospital, is deemed one of America's essential hospitals like Cook County, Grady, Henry Ford, LA County, you name them. And, there are these hospitals that are designated to take care of, I'll call them who they are, people who come from disinvested communities who are pretty much victims of this wildly sort of exclusionary economic strategy from way back in like the 1930s. And hence like redlining, you know what I mean? And has been wildly successful and impactful in doing exactly what it was. And so, the mindset of, folks in America is that that's the way that's supposed to be. These are, when you see these people, they don't do well. it's an expectation. It's like the natural order of things. It's inevitable. You can't boil the ocean. They love saying that, And so when you have a hospital like ours, and these are people who say the mission for the reason they work there is for the mission. But mission means different things when you don't recognize what you're looking at. For some folks, and I would say most, mission means I want to work at a hospital that takes care of these poor people, versus mission should be, getting to the root cause of how they got designated as such, and let's transform that, And so when back in 2020, 2021, when everyone, corporations, everybody was coming up with these public statements and commitments to equity, I was somewhat baffled because I couldn't understand that while people don't recognize inequity when it's clearly in plain sight all day long, how can all of a sudden people have this commitment to equity? And so I think what we did at our hospital to try to get to this, and for sure I was talking to Omar outside, and I was like, for years and years, like I've been using euphemisms to try to get people to understand it, because you couldn't say something too jarring because it would shut everything down. So what we did, our CEO, and he's our CEO now, he and the previous CEO decided to not make a statement, but instead to look inside our own house, to look across the entire enterprise, including, research, education, clinical work, HR, even our health plan, even public safety, and look for disparities, but with intentionality to close the gaps. And he's a strategist kind of person anyway. And so we all were divided into work groups covering those different areas. Each of the work groups was led by executive sponsors, and we were meeting every month. You had to come up with 5 or 6 disparities that you were going to close. They had to be vetted, whatever your proposal was, because if it looked like anything else we'd ever done, and then you're going to call it equity, it just wasn't going to fly. And so there was a high level of accountability. There were dashboards, and I would say that has the that is identify it, look at the data, interrogate the data back to the root cause, and make your impact there. And I don't want to go into all that in this question, but OBGYN was set that model for us. They have closed disparity gaps in maternal health. And that's the model that we use for everything. So it was sort of like a look inside yourself kind of a thing. And then the expectation going forward for everything is using that model and identifying root cause.
Thank you. Yeah, so it sounds like having work groups involving the people who are actually doing the work and having dashboards that are clear and transparent.
Right.
How have things been at Rush?
I came from practicing. Like I would just hang out in an ICU and drink coffee and round, and I really understood my job, and it was a lot of fun. And I went from that to eventually becoming a CEO, and I thought it would make sense. I thought it would make sense because in the ICU, if you saw someone sick, like Dr. Peeler, you knew how to fix them and you knew exactly what to do. When you're running a healthcare system, I learned rapidly the more good you do, the less your hospital performs. So I want to be really clear on this. It's a misunderstood point. The more right you do in healthcare, the more wrong your operating margin will report at the end of the year. And you can't get around that. And so when you strategically say we're going to build a healthcare system and we're going to fight inequity, which prior to the pandemic was something that Dr. James had to explain in a meeting carefully as to not offend the people in the meeting, right? To call racism a public health crisis was controversial, right? And in some cities, it still is. But the reality was it took the pandemic for people to realize, oh my God, like 3 people, do you have 3 times higher mortality of Black and brown people than of white people in the same city, in the same state, and in the same country? So it it was so powerful in front of everybody. But when you're running a healthcare institution, it's not hard to know how to fix that. There's nothing magical about a ventilator that works better on a white person than a Black person or on a brown person. It turns out if you get it for them before they develop ARES, they do better. So if you open your doors and you took care of people without resources, you would have had the same mortality across, regardless of who you were caring for. You can open your doors and to take safety net transfers and put them on ECMO cost our organization about $242 million in 1 year. And that's a lot for my organization. But if you say we're going to live our values, what better time than during an international pandemic? And if we say we're going to decrease the death gaps that exist in the country, what better time to do it when the gap is in front of you in real time on a disease? The only problem is there were hospitals in our city that made money during the pandemic. Hospitals in our city and there are hospitals in our country that did not do that same thing, but have the same equity mission. So I'm very sensitive to phrases around equity and flyers that are going around and big pictures and watching it, because the losses that we had paralyzed our organization's ability to recover the next year and the year after. Because when we got money back from the government, we just tried to make our people whole. So here's what we did. We took thousands of transfers from safety net exclusively. We have a gentleman named David Ansel would start the day and only call the safety net hospitals and say, send me the patients you think are going to code. We didn't want healthy people. We didn't want people that had insurance. We just wanted people that were really sick that we could save their lives, right? And that resulted in a massive enthusiasm and adrenaline surge of our providers. People, doctors, Dr. Peeler never felt overworked because she was working hard taking care of somebody. She felt overworked because she wasn't allowed to take care of somebody when she was about to save their life, right? So what happened was there was that first adrenaline surge and made everybody into it. Everybody was there. By the second surge, the third surge, what happened was people were starting to get not just tired, but the country went haywire. The country went crazy and things got upset. And so to stay focused, the more we did, so then here's what we did. We had one night where we took 7 transfers, 3 died, 4 survived. We went up and I passed out donuts. That's what a good CEO does. You pass out donuts. I gave donuts around 3 or 4 in the morning and said, we're in it together. We played the Queen song, We Will Rock You. We were in it, right? Everybody was there. It was my unit. Then about a month later, we cut people's retirement benefits and salaries. So the nurses that took care of them, the doctors that took care of them would go home in the first surge, take off their clothes in their garage, walk in their house naked, unwilling to hug their kids because we didn't know enough about the disease. And then they would work tirelessly day and night. And during the first surge, you put posters up and banged your pots, right? By the third surge, I cut their salaries because we had lost so much money, we were going to fall below our debt covenant. We couldn't pay our loans. So the question that was posed was, how does an institution face these challenges? You face them by doing what's right. We had unprecedented losses through the pandemic. And when the money came back, instead of build a clinic in the bougie neighborhoods, which would have a return, we refunded everybody's benefits. So I will be fired shortly at some point because we'll lose more money. But the organizations that invested the CARES money, the higher end neighborhood, to build a like an urgent care center, will recover. So when you look at the organizational challenges that exist in healthcare today, I started with the more right you do, the worse you'll do financially. I would challenge anyone to prove that wrong because we know what causes inequity. We know that Black women die of breast cancer more than white women, and we've published the hell out of it every year. We'll publish it more next year. You guys will publish it. That's what happens at Harvard. You guys just publish things over and over again, right? So we'll keep publishing it, right? Or is that wrong? Am I allowed to say that? I'm going to be banned from the meeting.
No.
I promise I'm going to stop talking after this.
I'll re-invite you.
Yeah, I promise I'll stop talking. So we keep publishing it, but to fix it, you got to open a clinic in the neighborhood where the people are dying. Opening a clinic in that neighborhood in our current payment model will decrease reimbursements and net lose money. Hospitals have to stay in business. They have to pay their providers. They have to pay for beds. They have to pay for IV tubes. The reason patients are getting to places because no one knows how to manage the need. We all want to solve I don't know what inequity is. Here's what I know. Healthcare is a human right. If you have a disease and we know how to treat it, and we have the treatments, you should get those treatments. It's not hard. If you have Crohn's disease and there's an infusion that works, I don't care where you are, you should get access to that infusion. That's what we believe then. Trying to do that this year is harder than it's ever been before.
Thank you. Thank you so much, both of you. And that's actually a good segue, kind of how do we practically move the needle toward equity? And so I'd actually like to turn to Dr. Saini. Thank you for joining us virtually. And Dr. Saini, I was hoping you would tell us a little bit about Lowndes' mission, the social responsibility index, kind of what the construct of equity is that you're working with in that rating system. And then I know I'm asking a lot of questions here, but essentially kind of what's been the impact of that index? And have you noticed any trends in hospitals since that's come out?
Hey, thanks for having me, Katie. Thanks a lot for those questions. I'm really honored to be on a panel with Omar and Thea. They're rock stars. So, before I answer those questions, I can't help myself. I gotta take a step back and just paint a picture of the context. How did we get here? And these are obviously just personal views, but I think unless we really look at some of the bigger trends, macroeconomic, political trends of the last 50 years, it's going to be hard to sort of really understand how we got here and where we're going. And so I just want to very quickly sketch something out, because that's the basis for at least my conception of what we're doing at Lowndes with the hospitals index. I think one of the first things we need to understand in healthcare was that there were big changes outside of healthcare, right? The rise of serious commercial competition from Germany and Japan in the 70s led, and a lot of overspending in Vietnam, I must say, led to a position where our economic leaders decided we needed to do something. And the thing we decided to do was first outsource to Mexico and the maquiladoras, and then outsource to China, and encourage China's accession to the WTO. And those changes had big impacts internally in the country. What we call the middle class, really, which is a large mass of workers and middle management, primarily in the manufacturing sector, really took a big beating. And we also made a fateful decision after World War II to tie health insurance to employment. So you couple those things together and something really big has happened, which is the economic base of large sections of our patients has been cut out from under them. And the healthcare system, on the other hand, has been a little bit insulated from that. And so there is a bit of a mismatch now. And that mismatch, I think, is part of the problem. In fact, I characterize it as increasingly there's a risk of a serious schism culturally and in every other way. And healthcare, has participated in all that. So, for example, the inequality we see in the rest of the country outside of healthcare, we're seeing it in healthcare too. I mean, I haven't done a very deep and special study of it, but a lot of things changed. The way we treat capital gains, changes in regulatory authorities, the Bayh-Dole Act in the early 80s, all sort of created this situation in which we moved to a market fundamentalist model, and that had a slew of consequences. And so part of what we're seeing, I think, is a cultural shift inside American healthcare that's been ongoing for a couple decades. Omar has said it very eloquently. I mean, there is now a business model, and the business model drives decisions. It's also led to growing concentration and monopolization and higher rates of pricing. And so when we think about all this, it's not a huge surprise, for example, that the medical profession increasingly feels like it's a labor force rather than a professional grouping. And maybe that was inevitable given the focus on RVUs and productivity and all the things that have been going on for the last decade or more. And while they may all be reasonable from an economic point of view, they don't really get us to where we need to get to. So my thesis really is that we're at a major kind of historical moment, turning point. And it's 100 years since Abraham Flexner said, a key issue is science. We don't have enough science in our medical schools and in our healthcare system. And when that got coupled to the post-war boom and the massive investment in academic research, pharma, device industry, and all of that, we got the medical industrial complex. And so these things have driven us to a paradigm. And that paradigm is part of the problem. And Omar just described it perfectly. So the Lown Index is really, it's an effort on our part to do our small bit to try to reframe the paradigm and try to encourage a shift in the paradigm. Or to put it a different way, in the 21st century, I personally don't think the problem is we don't have enough molecular medicine. I think the real problem is we don't have enough presence with the patient, enough listening. And so if we're going to reframe what it means to be a great hospital, which is what we've been trying to do, we need new metrics. And so we developed these metrics on the principle that let's measure things that aren't currently being measured. Let's try to do things that are publicly available. Let's do it in a way that's transparent. And let's measure things that really would be hard to game, or to put it a different way, if they were to be gamed, what would actually result would be a non-zero sum kind of thing. You get positive changes of the sort we want to see. So that was the thrust and the rationale for doing this. It's early. I'm not saying we're successful. We've just gotten started. So the index has three main pillars. One is outcomes, which are traditional metrics, 30-day mortality, readmissions, patient safety. The second is value, and we're the first really to report on avoidable care, unnecessary procedures, and we measure them and report them out. We also look at cost efficiency, which, because we're focused on Medicare, ends up being mostly about utilization efficiency. But the area that we've gotten the most notice, and why I'm here today really, is that we have an equity pillar. And on the equity pillar, we look at racial and economic inclusivity. It involves geocoding and mapping, using demographic factors. Another is pay equity, which looks at what does the highest paid person, the CEO, usually make comparison to the non-professional workers at that hospital. And the third is community benefit spending, particularly for nonprofits, in which the question on the table is, how much is being spent in a way that's meaningful to communities? So we use a lot of data, Medicare claims, census data, IRS, sometimes Bureau of Labor, et cetera. So you asked, how is it being received and what are we seeing? Well, when we first published it 4 years ago, it was received cautiously, I'd say, with some curiosity. And then with each subsequent year, I think there's been more and more attention from media, from hospital leaders, from policymakers and legislators. It's too early to assess the impact. I will say that the kinds of changes we need are actually going to be slow, so it is going to take time to see them. And as I said before, our main goal was to create a counter narrative, really, to the dominant narrative and the dominant paradigm, and to try to encourage the evolution of a counterculture, if you will. So our goal was to achieve that, and for that, we want to partner with anybody and everybody who's committed to making good faith efforts in that direction. And obviously, the work that Rush is doing, the work that BMC is doing, Rush in particular, the West Side United Project, all of those things are really, really important in my mind to get to where we want to go. We chose metrics that are hard, and we did that precisely because they're not easy, but because they're hard, to paraphrase John F. Kennedy. And so we think that if and when we do start seeing some progress, we'll have greater confidence that it's going to be much deeper and more structural and change that's really going to matter. So that's kind of where we are. And in the same way that multiple forces led us to this moment over many decades, I think multiple economic, social, and political forces are going to be necessary to get us out of it. And that means multiple solutions, different initiatives, multiple domains, all working together if we're going to pull ourselves out of this kind of tailspin. So, and lastly, the connect to burnout. Look, there's no question in my mind that burnout is a direct result of very routine, repetitive workflows, unnecessary administrative tasks, mostly related to our billing and collection system and our economic model of care. That's made clinical encounters transactional rather than relational. And that's not what we went into healthcare for, at least most of us. That's not what we went into it for. So that disconnect is real, and that disconnect is being driven by these factors we've mentioned. So I'll say I'm actually a technological optimist. I think that, there's no doubt in my mind that the second or third generation of AI will unburden clinicians. There will be more possibility of a sense of purpose and of genuine joy in taking care of people. But it's just that, it's a possibility. And so I don't think these gains are going to be realized really if the gains in productivity all go, into the financial beast. So that's a fact we got to face. And I think if we believe that, then I think this century, the first half of the 21st, is time for a big paradigm change, and we want to be a part of it. So that's what we've been up to.
Thank you so much. That was really fascinating. It seems like both of you have clearly have a tall order ahead of you. And so I guess kind of building on that, hospitals are businesses and business models drive decisions. Where do you see the best potential for organizational level action to be part of this counterculture, as Dr. Saini said? And how do you see external ranking systems fitting in either to your own hospitals or potentially influencing other hospitals to do what you've done? I'll stop there. I have a lot more questions, but.
So do you want to start?
No. Yeah.
Okay.
I'm told to do everything right for you.
No, please. No, not at all. We share, well, he has them, but they're friends of mine, my best friends. So anyway, first of all, I want to thank you, Dr. Saini, for recent recognition from the Lown Institute that BMC recently received as, being the most or one of the most diverse, medical centers in the country. But it's an interesting thing, the whole business model. Often, we'll think about, how the dominant narrative drives what safety nets should be, but that it should be, in my mind, about creating and capturing value. First of all, you have to recognize that, the costs of what you're doing in terms of treating patients who come in the hospital over and over and over again. And by the way, Massachusetts is a perfect example of how when you are not aware, when you don't have the right intentionality, when you're driven by a dominant narrative, because 90% of people in Massachusetts have health insurance and the outcomes are still no better. And so it's like, if you, in my mind, and the people I work with, all my colleagues, like if you provide a value proposition to a patient, and it looks like something to them that can that is designed to alter their life course trajectory. I mean, even enable them to switch socioeconomic lanes, enables them to step out of the line of need, because the way most people look at them is when they have food insecurity, for example, the greatest thing you can do for a person who is food insecure, and you have lots of patients who are food insecure, is to maybe, even if they're not patients, people in general, create more access to SNAP or to food stamps versus investing those dollars or those resources into a mechanism for them to never need them again, or why they don't have them. And, if you think about, two people, like I had a colleague who recently told me that their adult child boomeranged, was out on their own and then wound up back home. And I asked this person, I was like, did you send your son to Department of Transitional Assistance to sign up for SNAP? And we're friends. She was laughing, or colleagues, and she goes, "No, of course not." I was like, "Did you send them to Boston Housing Authority, to get subsidized housing?" She's like, "No." I was like, "Well, why is it when our patients come in the door with that same problem, you send them there, and for your son, you'll send them to a pathway of self-sufficiency. You'll connect them to those pathways, connect them to something else." And I feel like, first of all, there's no return on investment in charity in perpetuity. It just is no return on that investment. So if you know, if the government was my financial advisor or the person who was managing my money, I would have to fire them, you know, because they could be investing in things that would enable people to contribute to the economy versus depending on the economy and its continuously having to carve out things to actually provide subsidies and things like that for people. But people don't, I keep referencing the dominant narrative, but in my mind, that is what is driving things. Because most people think that those folks, you know, who come from these disinvested communities are like they are because it's their fault. They don't work hard enough. They're not smart enough. You know, they don't want to do better. But in fact, that is created. And when you're not aware of it, you are complicit in driving. It's inevitable you will drive it because you only think that it's just not possible. So just give them more stuff, you know, make it so that they don't fall down, but you don't enable them to switch lanes and be where you are, contribute to what you have. So I think that's what, you know, that we're constantly, you know, up against.
Thank you.
Yeah, no, I question, and I want to be really deliberate about this because rankings and metrics have been a huge deal lately. And but there's a difference in what the Lown Institute has done and what the traditional rankings have done. I think you have to step back and ask yourself, so healthcare providers don't go into this to get ranked. They go into it to save lives. They go into it to make a difference. So when you pick up a magazine and someone's ranking you based on your outcomes and the data is not real, it's incredibly frustrating and it's incredibly painful. And so, for example, I'm going to use an example. And so when the US News and World Report ranks orthopedics hospitals from 1 to 50, they exclude joint surgery. And they don't tell a lot of people, you have to read the small point, but most orthopedic surgeons do a lot of joint surgeries. So they're getting ranked by something that was excluded because of a series of decisions that were made based on mathematical equations. So people say we don't like rankings. That doesn't mean that we have to live in a data blind world. And this shifts to equity. You have to ask yourself, what is the intention of the rankings? What is the intention of the data? If the intention of the data is to drive a positive change in healthcare in the community, which is what the Lown Institute came out to do, of course, we'll be incredibly sensitive because we all feel like we're doing an incredible amount of work and no one wants to hear that they're not doing enough. But at the same time, until you turn the lights on, you're going to be walking around in the dark. And in healthcare, our challenges in inequity are we're spending a lot of time walking around in the dark. Healthcare systems are spending a lot of time talking about it. And I think the value of metrics is to say, are you actually doing it? The challenge of the metrics and the challenge that the Lown Institute will have is to make sure that you capture the efforts that are being done. So I'm going to build off of what Dr. James said, which is really powerful. We can build a hypertension program, and you've built hypertension programs that can kill hypertension. Really, we know how to treat it. But if you built a program that gave healthy food to a region to prevent the development of hypertension and obesity, you would net spend less money and make more of an impact for a community. The problem with that statement is it doesn't benefit the health system. Does that make sense? You could improve the health of your community and net lose money as opposed to improving your bottom line and fixing hypertension. So food desert, solving for a food desert, or teaching how to get into the pipe fitters union in inner city Chicago for a community, which will help increase the vitality of the community, will decrease the cost of the community. So the last time I'll talk about COVID, but we had a bunch of med students that went out and started testing homeless people, and 40% were positive. So we put a program together where we pull the positive people off and stick them in a hotel. And our argument was, if they're not spreading COVID, we're going to use less ECMO. If we use less ECMO, we're going to spend a lot less money. The benefit was to Chicagoland, not to the ECMO program of Rush, because we were still doing the same amount of ECMO. And so I think what we need is to appropriately and precisely call out healthcare as a field, and not just the health providers, which are taking an unfair burden of the fight against inequity. There's also pharmaceutical companies. There's also technical companies. There's companies you may never heard of called Epic that have some resources we don't have that could perhaps help fight equity. So we group in the amount of spend of healthcare, 20 cents out of every dollar. 4 cents goes to the group of providers that are being responsible for solving all of the challenges in it. So to summarize, we need the Lown Institute to actually be a stronger voice to come out with metrics in an interactive way with the healthcare communities so that we're appropriately calling out what's being done and we can drive positive change. But we don't need rankings that are so complicated and convoluted that they're not measuring what they say they're measuring. And I think not all metrics are the same. So you can't paint the Loan Institute in that same area. I would argue that metrics that look at equity should be discussed in boardrooms. And when you're doing that and discussing in boardrooms, you'll drive change.
Thank you all so much. I want to bring it back to kind of the beginning with the individual clinician. You know, we were talking about boardrooms and rankings that are public facing, and I hope more and more of the public read the rankings and the metrics done by the Lown Institute. But I guess, you know, to BMC and to Rush, how do your internal constituencies know if equity is being achieved? How do they kind of reconcile what they see on the posters and what's happening on the ground, essentially? Kind of what's the communication stream between the upper level management and those who are doing the work?
Yeah, so I can start with that briefly and just say that, like, you know, there's this, anytime you read a business book, and like when I became the CEO, everyone gave me all these books, like how to run a business, how to build a team, how to have executive presence. I didn't take that personally. Right? So in these books, they always talk about the story of NASA, you know, and they bumped into a person who was sweeping the floor and they said, "What do you do here?" And he answered, "I'm putting a man on the moon." Right. If you have an organization where the vision cascades from the boardroom all the way to the front line, you will have a higher chance of success. Like, organizations that come together around a common mission can succeed. Organizations that are schizophrenic will not. You'll see that in every group. If you've worked in different places, you'll have felt it, right? There's a value for playing the Queen song, "We Will Rock You." It's to get everybody in that team to know this is what we're doing right now. This is it. This is our goal. So we set out and said, we're going to decrease the death gap in the city of Chicago by half. It's 18 years. We said by 2030, we're going to make it 9. We have no plan on how to do that. We just lost $250 million and no idea. We hired Thea's best friends. We said, come down and develop a plan for us. We put a team together, but we stood in our boardroom and said, this is our mission. And this is pre-pandemic. This is pre-George Floyd. This is pre-Nike saying Black Lives Matter, right? This is like pre all of that. This is us as an organization saying, this is what we're going to do. So if you came into our organization, you knew from orientation, this is what we were going to do. We had 5 pillars. When you look across a healthcare system, all their strategic plans are the same. It's criminal. That's why you need external metrics. They all say we're going to help our community, we're going to improve research and education. They're all the same. Ours says we're going to decrease the death gap in Chicago by half. Right? So when you say that, and then you build the programs to do it, we don't know if we're not going to do it. But what better to have that kind of audacious or bold goal? You can say in every conversation, all right, you're having a budget meeting. That's part of the theme of the budget meeting. You're in a conversation about whether or not you should have 24-hour gym. It's part of that conversation. Everything that you do should be built around your core values. And if it's a core value, I would argue you'll know it in the organizations. And if it's not in other organizations, you'll sense it. And so there's organizations that have great portfolios that come out and say, this is what we're doing. And there's organizations that are doing the work.
Katie, could I have a word?
Yes, please.
Yeah, I just want to pick up a couple of threads here that I think are relevant. Certainly, we are very interested in developing additional metrics. We're interested in partnering with anybody who can help us develop metrics that matter and that are meaningful. And I think to some extent they will help. But I want to make another point, maybe a little sharper point and more inconvenient one, which is that we can improve equity metrics. We can improve the functioning of our institutions to a point. And there's a point beyond which we are not going to get to where we need to without major, serious systemic restructuring. It's a hard question to address, but we got to understand that that's the case. Because in what other industry is it the case that 2 people are buying the same product and one of them is expected or through third-party insurance is not worth the same economic value to a quote-unquote business as another? As long as that structural difference exists in our insurance systems, this is going to be a problem. So I think the other part of all of this is there's a need for hospital leaderships and really for this type of change, which is more of an adaptive change, not just hospital leaderships, but people coming from the middle tiers, even from the grassroots of healthcare organizations, to really partner and kind of change some of the conversations around advocacy as well, because those are the areas in which some of the bigger changes have to occur if we're going to really get it down to the finish line and not just move the ball 5 yards down the field. So had to say that.
No, thank you for making that incredibly important point, because it is, healthcare is different. And Thea, were you going to follow up on that?
No, I was just going to say, I agree with both of them now, having heard them both. It's so true. And the systemic piece is incredible. We are, we are treated by the payers the way that the rest of the world treats the people we take care of, so.
Thank you so much. And I think that we are right about time to move to a Q&A. So I will shift over back to Kelsey and Charlotte so we can hear from our in-person and virtual audience.
All right, wonderful. So just to kind of start us off with Q&A, folks who are in the virtual space, you can raise your hand using that reaction tab at the bottom and raise your hand there, and we'll ask you to unmute. Does anyone have a question in the room? You can kind of put your hand up and we'll add you to the queue. Yeah. Okay, so Ardita's one. I'm just gonna take a little bit of a cue here. Anyone else? Okay. Oh, Michael. Okay, Ardita and Michael. Excellent. We're going to try to trade off between the two spaces. So that's why we're looking for a little bit of a cue here. Why don't we actually start with, we've got one person in the virtual space who's raised their hand and we want to give them a chance as well. So I'm going to ask Alex Brown to go ahead and unmute and ask your question. Go ahead, Alex.
Thanks. Well, first, thank you guys for such a wonderful discussion. It's been amazing to hear all of your thoughts. And I have a quick question. Well, one is you guys mentioned metrics and how to measure equity. And I'm kind of curious of what hospital metrics or what metrics in hospital systems really leverage to measure equity. I think I remember hearing there's a dashboard. I'm just kind of curious at what were some of the measures that helped to capture that. But then also I'm really curious because hospital systems are businesses, as was mentioned, but what role could like value-based payment models or alternative models play in stabilizing hospitals that predominantly serve underserved patients? So I'm just kind of curious on your thoughts on that.
And Alex, before we turn to our panel on that, can you just say who you are and where you're coming to us from?
Yes. My name is Alex, and I'm a Presidential Management Fellow in the Innovation Center at the Center for Medicare and Medicaid.
Thank you.
And I'm also a bioethics, a part-time bioethics student. And Dr. Barry's my advisor.
Either of you want to take that start? Yeah. Well, yeah, let's start with the metric question. Vikas, can you help kind of describe a little bit more what the metrics are that help capture equity and maybe why you chose those?
Well, first thing I want to say is we have metrics, but we're really a subset of the universe of potential metrics. There are many more out there and many more need to be incorporated. So we're using a metric of really affects structure and access. So what we do is we look at the footprint of a hospital in terms of where patients are coming from. And we look at the geography of that area and look at the demographics of both people who are coming to the hospital and the people that are equally near or far who are not coming to the hospital. And we compare those two and we find systematic variation there in a manner that would not be surprising to anybody who understands, American society, but we were able to quantify it. And what we see is, certain hospitals tend to underserve poor and working class and minority communities, and other hospitals tend to overserve. So that's a metric, but there are many others. We're exploring a few now with Medicaid data, and we're going to be looking at more. There are metrics both in terms of race-based clinical algorithms. There's metrics related to ER transfers. There's a number of others, and it's a burgeoning field. So I'd say stay tuned and get involved, because you could help make one.
Yeah, and on the value-based care front, I think that value-based care works phenomenally well for broad-based communities. Value-based care doesn't work well if you have within a community a couple centers that can select out part of the patient population and leave another part of the patient population for different providers. And so the global strategy of providing more value for a broader population will absolutely work. It doesn't work it hasn't worked well in fragmented markets where you can pick the healthier of those out and select out against the unhealthy, and those end up in specific medical centers. I think the future of value-based care is phenomenal, but the reality is right now we can't survive on the payments from a value-based care program and cover our overhead tomorrow. So it's for the future, and it's something we're all going to have to get better at.
Great. Why don't we turn to an in-room question? Ardita, do you want to tell us who you are and ask your question?
Thank you for the great talk. I'm Ardita. I'm an MBE student. I'm a general physician from Indonesia. So I've worked in ERs and also non-governmental organizations. And I can pretty much say, yes, they have different values, although they do it good faith, which is to help people. My question would be that as a physician in the organizational level, how do you draw a fine line between being the economic business person, but also knows that there's problems in the front line? Because like from my short experience in the ER, we always have an image that the management of the hospital is not with us. Every time we encounter a problem, we feel that the burden is always with the frontline workers. So in your personal experience, how do you balance them? Thank you.
Yeah, well, I'm an ER doctor. And, I, at this point, work one shift a month. It's voluntary, but I volunteer because, first of all, I love the job. I love sitting in front of a patient who comes in with any range of emotions and just watching them decompress from listening to them, just watching that happen. And so that has yet to not, I'm still driven by that. I still love it, and it's still amazing to me. But, and part of what I'm doing when I'm in the ED now is talking to my colleagues about exactly what's happening and why that's happening, and getting them to see, how this translates into their jobs and that type thing. And, before I got this job, I was president of the medical and dental staff, and we were going through a time in the hospital. That's when healthcare reform happened. That's when they were taking away all the money that we were receiving for providing free care to provide, universal healthcare for everybody in Massachusetts. And in that role, in the room where everything happens, the med exec meetings, what's going on across the entire hospital. And the hospital was making hard decisions, for people, like cutting things and that type of thing. But that wasn't being translated to, the frontline staff. And that what my platform would be was, first of all, for the frontline staff to hear exactly what I was hearing in that room, and from those same people, having them come to the med exec meetings, all the VPs who were doing the dashboards and everything else, the CEO, all of them come there and, and talk to them. So there is always that, I shouldn't say always. I know exactly what you're talking about. I don't think it has to be that way. Pretty much nothing has to be that way. But you're right to raise that. So I'm actively talking to my colleagues and things about that.
So I really want to comment on that question because it's such a powerful question. Somewhere in healthcare, we became an us and they, a management and a frontline. So as an ICU doctor, like when I do a night shift, I'm still frontline, but then you throw on a suit and then you're management, but you're the same person. That mentality happened because of exactly what we were talking about, was a lack of transparency. If someone has a better idea of how to keep the lights on and how to make everybody how to increase engagement, increase benefits, and pay for free college for every employee's kids, I would love to hear it, because we will do that tomorrow. There is no magic like Wizard of Oz sitting behind hiding secrets. The reality is healthcare math doesn't work, and we haven't done a good job of cascading why that is down to people who are working. So if I'm working every year and I'm told I have to add a Saturday clinic, right? And then my email gets changed because of cybersecurity, and I can't access it from my house without going through 6 different phone lines, right? And then I find out that the CIO just bought a new car. I'm livid, and I'm living in an us them, right? If I don't realize that the mandates that are coming down made us do that, and we're all sitting in a room trying to figure out how to do it. We haven't done a great job cascading down the challenges that are there. So like what Thea just laid out is a very powerful story. There are boardrooms sitting there with people like dying over the decisions that they're making. And there's people that you're counting on to tell everybody else how hard those decisions were that didn't happen. So way down on the front line, there's this person saying, the hell are you talking about? This place is terrible. But if we share that and you're transparent about it, maybe you'll get solutions from the front line. So my favorite example was an innovation tournament a very famous hospital had. And it's one of the few famous hospitals not in Boston. And a very famous hospital had this innovation tournament. One of the things that won in the innovation tournament was the cups of coffee in the NICU. So the nurses in the NICU of this particular hospital said, why are we giving these 8-ounce? Nobody drinks in an 8-ounce Dixie cup anymore. Why is that what's there? The challenge that CEO had was, how the hell does that get learned in an innovation tournament? That's innovation. Our sense of communication from the highest level to the people that can make changes in healthcare are so bad, we can't even buy different cups, right? But someone thinks that's an innovative idea. That's an example of us not cascading, giving authority to the frontline to make the changes, making small business units so the frontline people could say, this is what will make for a better ER. Omar, I'll decrease wait time in the ER. I just need these 4 things, right? We have to go back from an us, them to a we, and how can you tell us what the right way to do to run this hospital system is with these challenges? Because I'll be very upfront with the challenge.
Thank you so much. It's a great question.
Charlotte.
Yeah, we have in the ether here, David Myers with a question. David, could you unmute yourself and let folks know what you were asking?
We've been talking about the mission margin conflict for 50 years, and I don't think we're any closer to resolving it in favor of the patient. I'm really happy to hear some of the comments that have been made from the Lown Institute and Dr. Lateef and others, but and I think somebody else on the chat has asked, well, what can we start doing today to make a difference? The system is so sick and so unable to accomplish what we really want to accomplish. Where do we start, and what are the first steps we can take? Does it have anything to do with changing the salary structure so that the multi-million-dollar salaries in the C-suite are somehow used to give frontline care and even things out on that respect? Other ideas. I'm happy to hear whatever anybody suggests as a starting point.
Maybe it's organizational culture, because I feel like many things, it drives many things, in terms of what you're willing to do, what you want to do, what you think is possible. And I mean, I have a lot of colleagues that I work with on similar stuff right here in town. We sit at same tables every month, and I'm about to do a meeting right after this at 2:00 with some of them. And what I have found is it kind of starts with organizational culture. Some things they might want to do and can't do. Some organizations might want to focus on this or focus on that and not this or that. Some may be of the ilk of you can't do it any different, and this matters more to us. This matters to our board, this, that, and the other. So, I mean, I think a lot of it is there. The other thing I want to say is whenever we're trying to solve these kind of issues, be they something as systematic as what we're describing and discussing here, we always go in a room and sit down and try to figure out how to do this. And sometimes I think we should start with the subjects of that issue, talk with the patients, talk with the communities. I mean, ask them, what it would take or whatever, and then maybe we can decide about or use them in whatever it is you're have them at the table with this. That probably sounds crazy to people because we're talking about the culture of medicine and how the payment system works and these kinds of things. But I just think maybe we, organizational culture, having some different kinds of voices like in the mix. And for people who live in Massachusetts, I'm going to say that the CEO we had until we lost her to the state as the new Secretary of HHS, Health and Human Services, I think that someone with that level of insight and intentionality can begin to change a system at that level, just because she's in that role and that she has that level of insight. I've seen some of it already. So
I think building off of that, we have, oh, sorry, go Vikas.
Oh, sorry. Yeah, just two minutes. I'd be the first person to say that, transparency is not enough, but I'd also be the first person to say it is a damn good first step. And so one of the questions I think that helps guide me in what would we do next, what should we think about next, whether it's our own work or whether it is legislative or advocacy work, is what do we imagine that future healthcare system is or should be? My own view is, and this is just a view, but it's just healthcare is not a commodity, because really health is the product. Yeah. It's not transactions. It's not a procedure. It's health. And that's not a commodity in any meaningful sense. And if that's true, then what we have to do is imagine a system that functions differently, like a public utility, like the school board, like something else. So once you start thinking that way, then the question of transparency becomes very powerful. Like, it would be useful to see all sorts of budgets. It'd be useful for the public to understand what decisions are being made and on what basis and how priorities are being set. So there's a lot of different next steps one could take if one takes that approach.
I just want to make one quick comment. To me, to get back to both what you said, Vikas, as well as what Thea said about culture, I think not to sound too Pollyannish, but I feel like transparency is like the most important first step and could be done today. Like changing the entire healthcare system will not happen today, right? Like changing the way that the business is run and everything is structured, but certainly having people like Kate Walsh be in those positions are incredibly important. And we do need to have longitudinal, long-term goals towards achieving that. But I think that with more transparency, there is more trust. And so I think you'll actually get further. There was that famous study in the New Yorker probably 15 years ago, or not study, the New Yorker doesn't do studies, but writes very long articles about studies, about the bell curve, called the bell curve by Atul Gawande, when all of these hospitals were very scared to share their CF outcomes and data. And they were essentially forced to. And they were very worried about the kind of financial ramifications of what if someone looked like they were worse. But in actuality, everyone got better by virtue of sharing data. And I think that it increased public trust and it increased the trust of the people who are in the institutions. And I think so if there's transparency by executives, I think that people on the front line will feel more trust in their hospital, even if their hospital can't achieve everything they want to achieve today or tomorrow, but they will feel like they are working for an institution that they know is working toward it. And so they want to stay there to help work toward it themselves.
I think that just to kind of pick up on something that Vikas offered us, which is to say that we might be in a place of diagnosing the problem. But at the same time, there's real work to be done in envisioning a system that is capable of meeting the values that ought to be orienting it. And so that's among the things, just in consideration of our being at a Center for Bioethics, that the work is not simple. And really appreciating that there may be more than one way to generate a system that realizes a multiplicity of values, or even a singular value like equity. So just to kind of inquire with the folks who are in the room and on the chat as well, as to how you think about being clear about the values that guide a system, and how do we trade off between different considerations of equity as well. Thinking about, for example, considerations around pay equity and instances in which it is true that there need to be cuts to services in order to facilitate the service to relatively disinvested and disadvantaged communities, maybe cuts to services and to payroll. So there are different types of equity that may well come into making the system better. And how do we make trade-offs between those types of equity as institutions? That's not a question for the panel unless you're interested, but I do want to, I'm going to bring it back to the in-person group here. I know that we had a question from Michael Young in the back. Do you want to say who you are, Michael, and what your question is?
Hello. Yeah. Hey. I think my question's been mostly addressed. One of my students, Thea, presciently posed it about frontline providers, because I really wanted to get to the core of as much as we've been talking a lot about institutions and equity, talking about bringing it to burnout as director for medical ICU. And having seen all these frontline people put in at the first surge, as Dr. Lateef described, but progressively get more demoralized, and being at BMC with Thea, I think there is the kind of aspirational planning for long-term change, but then there's the what do we do today, which Dita asked. I think you guys have addressed the question, but I am interested in how any other solutions, and specifically in professional societies, any examples anybody's seen as to something that's been particularly innovative for physicians on the front line to help them manage this moral distress that a lot of them really do have at this point, and just kind of like a moral kind of disappointment, if you will.
Maybe before we invite the panel in on that, I'm just looking at time. I wondered if we could add in a question from the online group. I know Lachlan has been waiting, and then maybe we can double barrel some of our responses.
I won't repeat things that I put in the chat here. This is going to be an invitation, Thea, for Dr. James, but others, because one of my first things was the macro level. What one thing can people do? I also had a couple of micro suggestions in the chat about what any staff can do. Passing someone in the hall and thanking them, expressing pride in them is a tiny thing, and a recommendation about patient-family advisory councils in Massachusetts, which currently are just ignored. But one of the things I think anybody in Massachusetts can do, and what Dr. James' comment is, I was all day at the State House admiring Dr. James and others testifying on behalf of a health equity bill in the legislature that needs much, much more support, that aims to set up a state office of equity with structural systems, including systematic ways of having the voices of marginalized people involved in decision-making. So I wonder, Dr. James, could you just offer a couple of sentences about what people in Massachusetts can do so that what you were so eloquently calling for has the best possible chance of becoming law?
Thank you, Lachlan. I feel, that particular day, that particular bill, the HEC Equity is compact is like 70 leaders of, they're not all of color, but mostly they're executives and all levels of people. And there is a bill that we are arguing for that does exactly that, or I should say advocating for, that would put someone in a position that speaks like us on this panel here, and it would assure that these things could happen. And so I would say that people of Massachusetts can just, can advocate for that, in the same way that we're doing. That's how we got healthcare reform. That's why we have, 90% of people who are health insured, but hopefully the outcomes will be better than that. has done, because even with that many people insured, the outcomes, are no better. But I think now that we are farther down the line, we have more insight into root causes of how this happens and the level of intentionality that is required to transform. I feel like we have a great opportunity to do that. So people of Massachusetts, they could just like pound the pavement, beat the desks, march, whatever, your voices are really impactful and needed. And we would be, we'd be the first state in the country to do that.
Yeah, I put in the chat a link to the Health Equity Compact and the bill with information about how to contact your legislators.
Thanks, Lachlan.
So just as we're starting to, I think, wrap up today's conversation, I wondered that one of the elements of the conversation was, what is the role of these external drivers, things like ranking systems that help, as I think Omar was noting, kind of shine the light on what we're doing so we're not wandering around in the dark. I just wanted to maybe bring in Vikas at kind of as we're closing out. You've mentioned that this was something that is relatively new, right? Only a few years old, the hospital index that the Lown Institute produced. What are your plans for it going forward? Do you see a role for it in, as you said, generating a counterculture? How do you think about really advancing the work that index is doing to support and give credit where credit is due, I think, for really amazing work that institutions are doing, but also facilitate the agitation that we hear in the room from a place of science and values. So do you want to say a little bit, Vikas, about next steps for your index?
Sure. A couple of things I'll say. We're getting a lot of interest and queries from both regulators and legislators and community-based groups around the country. So already there's interest in sort of taking some of this information and trying to put it to use in the form of advocacy and the like. But, to a point that Omar Lateef made and that other hospitals have made when they've reached out to us, there are things hospitals are doing that we're not reporting on. And we'd love to develop metrics that incorporate some of those activities because they're clearly aligned. They clearly should be part of a kind of reporting metric, but they're not systematized. They're not, there all over the country. And so we're working on that. What I'd say is that we're starting to look at medical debt questions, billing and collection questions. We're also trying to do more precise calculations of community benefit spending in relationship to the tax benefits. We're starting to look at Medicaid, as I said. So, the way I'd put it is we're trying to make it both more practical and serviceable for people who want to use that information to advocate for change, but we're also trying to make it more, increase its fidelity so it's truly reflecting, people who are performing well. And in each of those areas, there's work we're doing now and work we continue to explore. So I'll leave it at that.
Thank you, Vikas. We've just got another few minutes. If there are any final reflections from the panel, and I know, Thea, you have to jump right at 2. Is there anything you wanted to close us off with from your perspective?
Ask people to, I'm sorry. I would just ask people to think beyond whatever you think. Seriously, just think beyond that, just go to root cause for things. And I just want to share one example of that. I did mention our OBGYN department earlier. One of the things that they found looking for disparities was that Black women were having postpartum hemorrhage at about twice the rate of white women. And so in using that model of interrogating the data, the first thing that they saw was that it was associated mostly with preeclampsia, hypertension, and pregnancy. And, particularly in later stages of pregnancy, the treatment is delivering the baby. And then that they looked more and the data showed that the faster that decision was made, the less likely those outcomes happened. And then they looked at the data more again and saw that the doctors were taking twice as long to make that decision in Black women than white women. So what they did immediately, just immediately, was to standardize I mean, it's a bit healthcare systems because doctors don't like that, where you tell them what they can do and not. But we did it. And guess what? The gap narrowed significantly, I might add. But we didn't leave it at that. We also got the voices of everyone involved to sort of like add context to that variation in decision making. They talked to the doctors, they talked to the patients, nurses, everybody who was involved in that process. And there's this analysis that they did. And it turns out that, there are a lot of things involved, but there's mistrust on both sides. The patients wanted more education around like preeclampsia, more about postpartum hemorrhage, everything, so there's education, there's mistrust, but right at the center, if you guys were to see the analysis diagram, was bias. And so many things sort of were, bounced off of or grew out of that whole thing. So we took all of that information from people and asked the patients to help create things that they wish they had, like they wanted a chat bot. We did that. They wanted more education. We created videos and things for them. And I will say, of all those things and for, doing all those things that we did in just 1 year, readmissions for postpartum has gone down by like 20% in just like 1 year. So I'm just asking, like, you have to think beyond what you think is possible, and you have to have intentionality to actually do it. There's some willingness. You have to be willing to be transparent. You have to be willing to, recognize that you're going to see some things you don't want to see, because it was hard to like even watch some of the comments from the patients, to have that on a Zoom like this with that many people inside the institution. It would be like silence. You're just silence, but you have to be willing to get to that level with an intentionality to be transformative and do something different.
And thank you, Thea, if you have to
No,
go.
thank
It's
you.
okay, we know.
Yeah. Yeah.
Okay, thank you.
Yeah, I have to run too, because I have the opportunity to visit my son. So I move my flights around so I can stop in Philadelphia on the way home. He's been in college for a week and a half. So my wife is making fun of me. Everybody's coming down on me. Michael's question is very powerful. By no intention was it meaningful that we didn't answer the question about how do we stop burnout. We're at an inflection point in healthcare right now, because the challenges financially are so profound. And if there was a simple answer to how do you get the front line and make them happier, how do you keep every program better, how do you ensure that, yoga is not going to solve wellness on the front line of the emergency room after a pandemic, but it may help. Saying hi to people matters. Treating people like human beings with respect will matter. And as a nation, we sort of came away from that. And as a healthcare group, we're really broken apart. And one of the questions, I believe it was Lachlan that brought up is, what could we do now? Or what are some of the changes we can do now? We need to do a better job working together as a healthcare community. We can't have one hospital advocating to their local legislatures and another hospital advocating for different things and a third hospital advocating for different things. We have universal problems that need universal solutions. And we have to collectively table a whole lot of ego to pull ourselves together to advocate in a way that makes common sense, because the challenges we have, people wouldn't believe how simple they are. If we can't get cups to an ICU right now, of course, we're going to have burnout, right? If the people don't have the authority to do that. So we have an opportunity now to shift to change and to put action behind our words. But I think I would close simply with, it'd be a great chance to work together to do it instead of work as competitive healthcare systems to tear each other apart while we're facing the same problems. And that's what happens in Chicago. I don't know about Boston. Maybe you're a lot more touchy-feely than we are down there. Yeah. Thank you.
Thank you, Omar.
Thanks so much, Omar. I think we're at time. Thank you. Go ahead.
Considering that we're at time, I want to first of all thank Katie for really bringing this to this consortium, the kernel of this work, and of course our incredible speakers. I'm going to turn it over to Charlotte to close us off for today. Charlotte, why don't you take us home?
Yeah. Thanks, Kelsey, and thank to the faculty on this panel and to the incredible audience who have contributed your thoughts on the chat and your questions in the group. It's interesting that we began the conversation with clinician moral distress on being unable to take care of patients who don't have insurance or other resources. We moved to what can be done at the organizational level. And then from there to, highlighting the need for collective action, both with respect to the immediate problems we discussed and to the larger system, the structural factors in the medical industrial complex, and the real need for everyone to work together and to find ways that we can rethink and reorganize the system. So we want to say thanks to everyone who's participated and also invite you to come to further panels in our series this year. If you came today because of an interest in equity, you'll likely be interested in a number of the upcoming programs. The topics include mapping the future of the profession of psychiatry, partly with equity in mind, setting ECMO triage policy at the organizational level and the regional level, ethical issues in digital health innovation and in the intersection of social and medical care. Our programs will all be announced on the website of the Harvard Center for Bioethics. Thank you again for joining us today. We hope to see you again. And we're adjourned.
Thank you. Thanks, Vikas.